All this is Dr. Mobeen Sayed from drbean.com. Welcome to one more show. So today's day is a little jam-packed for me. So we have this discussion. After that, I have a seminar or a webinar with a group of students, medical students who are looking for doing USMLE. After that, at 2 o'clock Pacific time, I will be live with Dr. John Bream. He's a physician, ICU physician in New York. And he had asked me to appear on his channel. So you can actually find him on Facebook with Dr. John Bream, B-R-E-A-M. And then, of course, in the evening, we have our own regular talks as well. So with this, let's start our discussions. Hope everyone is doing good. Here are the things I wanted to show. And first, once again, the credit. So this is drbean.com. Here, credit goes to Cool Bean David. Israel just sees 38 new cases, the lowest daily tally in a year. Fatalities, infections rates continue steady decline since pandemic's peak in January as country reaps benefits of vaccination drive. And I believe what they're showing here is the people just meeting each other and sitting together. The things that we used to do about a year ago that seem so distant at this time. So if you see here Israel's numbers, look at this. Just look at this. So this is 315. And after that, there are actually either probably not reported yet. Today is actually Tuesday, so should have been reported. So no cases reported here yet. And then if you see here, the lowest active 1,666. So even with their first tiny start, and then when they went down, they controlled it, it just became that way, was 2,000. And now the total active cases are 1,600. And again, touch wood, don't want to jinx it. This is great. And if you see here, the number of deaths are 2 and 4. This is amazing work on Israel's side. So this, I think, is something to look at. Now, I totally understand that for bigger countries to say that, hey, we can do this 100% vaccination drive in a few months is going to be very difficult. For example, India probably cannot pull this off just because of the logistics and the large population. So they would have to work with social distancing, lockdowns, and other. And if you see here, India has been in lots of pain, but their cases are now dropping. So 300 and this may be a reporting issue. We'll see how the trend is. But there was at one point 354,531 reported. And then here we have 319. So still high. It's not a good situation. Trend is still high. Active are still high. But I think that social distancing is needed. Masking is needed. And then, of course, I'll continue to say this, ivermectin is needed. So number of deaths are very high here as well. So India is not doing well. One more thing I wanted to show, and this is also a Cool Bean who sent it, and I thought it was really interesting to share it with you. This is a BBC report. So again, please keep in mind, this is not a study in itself. Coronavirus, how the common cold can boot out COVID. So what they did was, there were some scientists, and what they did was so let me draw for us. So let's say here is a cell, and this cell can have viruses in it. It can have infections in it. So what they found was rhinovirus is the most common cold virus. Mostly when our nose is running, most of the time, 40 to 60% of the people, it is rhinovirus. And then there are other human coronaviruses, respiratory syncytial virus, and so on. Rhinovirus, when it infects the cell, it prevents further entry of the other viruses, including coronavirus. So there is a conjecture here. It's not a proven thing. It is an in vitro study. So what they did was they put some cells in a petri dish outside the body, and they looked at those cells and they infected them with SARS-CoV-2 and with rhinovirus, or they put these two viruses together in here, and guess what? SARS rhinovirus won over SARS-CoV-2 for infecting the cell. And that actually is a good thing because rhinovirus does not kill that often or that much, although flu can do that too, but common cold is here. And they even gave 24 hours head start to SARS-CoV-2 to say, you know what, SARS-CoV-2, you can go first. And even then, when they when they administered or when they added rhinovirus, the rhinovirus won out. So it is an exciting thing. So SARS-CoV-2 never takes off. It is heavily inhibited by rhinovirus, Dr. Pablo Murica told BBC News. He added, this is absolutely exciting because if you have a high prevalence of rhinovirus, it could stop new SARS-CoV-2 infections. So this is 23rd March. This is also by a cool bean who just sent it to me. So I thought I would discuss this with you as well. So here we are. How is Pakistan doing? And then we would answer your questions. So Pakistan has the third wave, larger and continuing as well, which is not good. Active cases are high as well. And I would suspect that deaths are following that too. So not a good situation there either. Okay, so question, COVID vax is killing says, why should we take an experimental vaccine with experimental technology for a virus that is 99% survivable? So the very simple answer, first of all, the taking of the vaccine is your choice. So I don't care what metric you tell yourself to justify it. If you're not going to take the vaccine, then that is your decision, not mine. And I have never pushed anyone over here to take the vaccine. I am a pro-vax. I have taken my Moderna first dose. My family has taken the vaccines as well. I would take my second dose as well. And that is where I stand. Now, the comment about 99% survivability is actually an incorrect way of looking at this. But I have talked about it before in my previous discussions as well. Jenna Taylor says, oh, so that's an FYI. Blood-brain barrier can be compromised without having major symptoms. Yes, if there is some inflammation, but still with the inflammation, we can see it. The problem is, Jenna, if the blood-brain barrier is compromised, then there is going to be some symptoms because the result of compromise is some substances or things entering the brain and causing harm. And if there is nothing happening, then it's really not compromised. But I understand what you're saying. Claire says, Kitty Bean here. Welcome. Colin, welcome. Ditching the grind says, question, Dr. Bean, what type of coffee do you enjoy from Starbucks? So nowadays, since my fasting times changed, I have not gone to Starbucks for some time. I take Pike Place, and I don't take cream or sugar. I just take I go in there and I say I need one grande Pike Place, and that's it. Nowadays, I have been going to 85 degrees centigrade. That is just because they are open at the evening time. And I take their Americano. And once again, Americano means there is not going to be any cream or sugar. Margaret, hello, Margaret, how are you? L, hello, how are you? So now let's see more questions. Nick says, all absolute risk is for the overall population, but can be 4 to 12 times higher depending on comorbidity, social and economic situation, and smoking. And thank you very much. I think this is a topic I need to do, absolute risk reduction versus relative risk reduction. Buzz Night Gear says, I like it instead of year. Buzz Night, I've seen you after a long time. Can you explain why you can't take ivermectin if you've had the BCG vaccine? who said that? So I have to first read why somebody is saying that. I thought ivermectin has not, BCG vaccine is not a contraindication, but maybe I'm missing something. Ruth Wall says, have you released the panel of FLCCC, as I've not been able to find it on YouTube? I did get to see Dr. Tess Laurie, which was a great interview. Thank you both. So are you talking about the panel discussion that is on FLCCC site? So if I go to YouTube and say FLCCC press, and then I go here, let's just go to YouTube actually. YouTube, FLCCC press, YouTube continue to show me my own videos. So this is the FLCCC. Over here, we have various videos, including the panel video. So somewhere here, if you see, this is the panel video. This one. So this is FLCCC. Continuing on. Dr. Bean, Dr. Corey, when he did his talk with Dr. John Campbell. Janet Taylor says, Dr. Corey hasn't been on board with ivermectin, in my opinion. Joy Fisher says, question, what type of pain from vaccines, like arthritis in already existing areas or in new areas of the body, never with arthritis before, worse than arthritis? So I think it is different, but usually the joint pains, for example, knee joint pains or wrist pains, so any joint can be aching, but usually the knee joint pains are more common. There can be generalized pains as well. So what happens is when our muscle, so there are two types of reasons for the muscle joint pains. One reason is that there is inflammation in and around the joint. So that is causing the joint pain. The second reason is that sometimes our muscle, when they become fatigued, let's say vaccine, you took vaccine, someone took vaccine, they became fatigued, the muscle became a little loose, and the muscles are now not holding the joint with the same tone that they were maintaining before, which causes the bones to kind of articulate in the muscle, move in the, not in the muscle, in the joint, in a slightly different way, and that can cause pain as well. So altered support system can cause pain in the muscle as well. Claudia Gubble says, unpopular question, but can there be a link between the surge in vaccination and deaths in some countries like Cambodia? I have to look at Cambodia itself, but if you see, follow Israel. Israel has, if I go here, the short answer is no, but I'm going to show you for Israel, for example. Israel is now here, 10.4 million doses administered, 59.5%, so 60% vaccinated, almost reaching herd immunity, 66% to 74%-ish the herd immunity, although R0 has been changing, but we can take that as a baseline. So about 60% with the dose 1 and 55.5% with the dose 2, and look at the Israel's results here. And I just showed you this news here as well, that Israel sees just 38 new COVID cases, the lowest daily tally in a year. So, Claudia, good question, but no. Aurav AK says, sir, is it possible to set up a standard dose for all of the ivermectin with vitamin D as prophylaxis? So if you wanted to say that standard dose for everyone, usually it is not advisable, because then in some people it would cause toxicity. If you take the adult dose and give it to a very young child although higher doses can be given, but this can cause toxicity. So usually the therapeutic doses has been 150 to 200 microgram per kilogram of the body weight, or 0.15 to 0.20 milligram per kilogram of the body weight. Although nowadays, because of the variant, and it is surging fast and it is contagious, a higher dose is recommended. For example, somebody asked me over this weekend in the conference that, hey, would you recommend your own dose for prophylaxis to go up to 0.2 instead of 0.15? And I said yes. And if you hear Dr. Corey or other folks from FLCCC, they are now recommending 0.4 milligram per kilogram body weight, so almost double of the previous one. Elk says, thanks for all the great talk. Have an Americano. Thank you very much. And stay happy and healthy as well. So one thing that I mentioned yesterday, and from vitamin D, I remember it and I'm going to mention it again. And I was given permission to share it online, even with the name, but I'll just use the first name. So let me first answer this question and then a related comment as well. Question: is vitamin D 60,000 IU weekly dose as effective as 4,000 IU daily dose? Yes. So that is one, because vitamin D can be stored in the body, in the fats, and then it can be slowly removed. Having said that, we have a cool bean, very dear to me. He and I are directly in contact as well, has been speaking with me since, I think, couple of months at least, with his symptoms after the dose 1. So he received the dose 1. He has developed generalized GIT disturbances. He cannot eat food very well. He would develop a he'll become bloated, gassy, and GIT would just be upset. So naturally, the result of that is that he stopped eating very well, which in turn caused him to lose about 20 pounds of weight. So 1 second, I'm going to open the door for Luffy. So, and he had been reporting this, and he had been taking, I believe, about 10,000 international units of vitamin D on daily basis, usually with the dinner. So he had done his test with the home-based vitamin D testing systems, and the result was that they showed 40 to 50 nanogram per milliliter. So he thought he was in the range of 30 to 100, which we usually think it's fine. And then when this all kept happening, a few days ago, he developed so much of a GIT pain that he thought he may have been developing thrombosis. So he went to emergency. They did his D-dimers. They said it doesn't seem like it is thrombosis, and they discharged him. Then he came back and he said that he thought that this may be, I should check my vitamin D levels. And so he checked his vitamin D level from a professional lab, and they were, I think, 109. So he thought he was in the higher level. I want to use the word toxicity, although there are going to be many comments here that vitamin D does not cause toxicity, and we go to sun and we make a lot of vitamin D. But vitamin D, thinking it is too high, and the next day in the morning, he says, I got up and I was much more improved. And he's saying that since then he has been the symptoms are going, he's been eating again, and GIT is not upset the way before. So the point of saying this is not to scare you to say there is going to be a toxicity, but more importantly, if you have any symptoms of GIT or disturbance, check out your vitamin D levels, or give a break for vitamin D for a few days to make sure that you are in 40, 50, 60s level instead of above 100. So just an anecdote. This is just one anecdote here. All right. So let's see. Lucy Lynn Smiles says, can you provide any trials that show those who took mRNA vaccine are no longer producing the spike protein from their own cells to make sure the mRNA does break down on continue how much antibodies? So Lucy, good question. I would probably flip it and say, can you show me any trial that show that the spike proteins are continuously made? So the burden is not on me to prove it is not made. The burden is on someone who thinks it is made. And I have done a video for mechanism to show why it will not be made. But if somebody thinks that, hey, you know what, the cells are just going to make spike proteins forever, then they should show it so that then people can come back and say, here is why it is not. I have shown the mechanism. It is impossible for our DNA to become changed. It is impossible for our cells to continue to make spike proteins forever. GB says, sir, what is the possibility of thrombosis in COVID in individuals who had previously developed HIT after AZ? So in my opinion, someone who had developed heparin-induced thrombocytopenia should not take AstraZeneca without talking with their doctor, telling them prior, and then deciding if they should or not, and is this their only option. Because if you think about it, on the flip side, if somebody develops thrombotic thrombocytopenia from vaccine after, let's say, AstraZeneca or Johnson & Johnson, they are asked not to use heparin, maybe because they may be hit as well in addition, and now the patient situation will be aggravated. Reverse that as well. If somebody has hit or known to have hit, they may develop AstraZeneca-related blood clots as well. So it is not a guarantee that they would, but it is possible. So I would just ask them to be more careful, talk with the doctor, and then decide. Z Harun says, tachycardia and long haulers, normal echo, what's the reason, best treatment? So this is something that is actually, I'm working with a few long haulers as well who have this. The tachycardia depends, what is it? Is it the postural tachycardia? That is when I'm sitting here and I just stand up. Will that cause tachycardia? If that is the case, then it is really not the heart itself, but more of the autonomic nervous system and the cardiovascular system's behavior. So what happens is, if I stand up like this, my blood would rush downwards because of the gravity, and as I'm coming up, and that reduces the blood flow to brain, which causes us to kind of have a feeling of a quick dizziness. But our body counteracts that by increasing the heart rate for a few seconds, and that keeps the blood pressure up. That heart rate is not felt by us. We actually, every time we get up or we sit down, this happens, but we are not aware of it. The problem becomes that when we become aware of it, that is called palpitations, and there is a problem with the autonomic nervous system, the vagus nerve somewhere, or the working correctly. So it really needs to be looked at, that what kind of tachycardia is present. I agree that this is something that is present. What happens is, over a few months, it actually starts reducing. The question is, can we abolish this whole issue altogether? And that's still some of the folks around me are updating me, so we'll see what happens. Rahul says, ivermectin with colchicine and steroid in early stage. So I am actually a fan of ivermectin, a fan of colchicine as well. I've done a discussion about colchicine. It is great as well. Steroid, I would probably not start, although the doctors in India and Pakistan, I'm sure Bangladesh as well, they would have been, many of them start steroids from the day one. As soon as the patient arrives, they start steroid. In there, the important thing to note is that patient does not arrive at their clinic on the day one of the symptoms. Sometimes patient is at home for a couple of days. They think it is just a fever, or maybe I'm okay and it is just a feeling. So it is not necessary that they reach on the day one. They can be a little late. And doctors start the steroids then. In the UK study, they started steroids about 7 days into the symptoms. So I am more of opinion to start it at 5 to 7 days, but there are so many doctors who just start it on the day one with good results. The most interesting result that they report, and I know a doctor here in the US as well, she starts on the day one as well, or very early as well. They say that the breathing issues or the oxygen saturation issues are not seen. So patients feel very well if they are taking steroids. Colin Hamill says, since rhinovirus beats COVID, were we stupid to lock down through winter in the UK since just about everyone gets a cold annually here? It may be that it was an incorrect thing to lock down during the winter. But the thing is, Hemi, there is no study for that. This study is in vitro. It shows something that is interesting, which means that what you're saying could be right. So Patrick Moe says, when there was a problem with high vitamin D level, wasn't it in reality a problem with high calcium? One effect is total loss of appetite. Absolutely. So vitamin D alone is not the problem. Vitamin D causes the calcium mobilization. Vitamin D causes more absorption of calcium. The calcium may be laden in the GIT cells as well. So yes, so these are issues that are mixed together. But the basic driver is a level of vitamin D. So if you said, hey, remove vitamin D, can calcium do this by itself? That would not happen. So it is a combination. And the thing is, what is the right vitamin D level? And I think we all have to figure it out. Yes, conjecturally, they say 30 to 100, but what is right for one person is their body is going to be unique for them. So FRUIANDISES says, vanilla bean, can messenger RNA or vaccine genetic material travel to the heart brain? So I did this discussion before as well. Let me show this. Maybe it can also tie back into the previous question too. So vaccine RNA. So if I go here and let's say this is a deltoid muscle. In this muscle here, we have injected vaccine. When we inject vaccine over here, there are cells here. There are muscle cells, there are fibroblasts, there are dendritic cells, there are macrophages, there are other cells that are sitting here. There are neutrophils, there are NK cells. These cells are all sitting here. And what happens is the vaccine starts entering those cells. Vaccine is a lipid nanoparticle. So that would very rapidly diffuse through the cell membranes and enter the cells. So first thing, that for the lipid nanoparticle to find its way in the blood and then just go and become spread in the body, the amount is not sufficient. Imagine this, that we make lipid nanoparticle every time we eat food. So when we eat food and there are fats in the food, they are absorbed from a GIT in the form of lipid nanoparticle. We call them cholesterol particles, or chylomicrons we call them. Now, those tiny particles circulate in our body, and depending upon the amount of food we have eaten and the amount of absorption, that is how the particles will be in the blood. Here you are giving, let's say, 0.5 milliliter. How much particle can be there? And that particle is now continuously getting absorbed. When they get absorbed, they bring in messenger RNA inside the cell. And that messenger RNA would then allow the cell to make the spike protein. Those spike proteins are then shredded by, who would tell me, endosomes, correct? So I discussed this, that endosomes act like shredders, just like we take shredder and shred trees or break down structures. There are endosomes that would break down these spike proteins. Those spike proteins are now broken down inside the cell into smaller pieces. Then those smaller pieces are loaded, as we use the term, they're loaded on the MHC 1 and 2. So those folks who think that somehow spike proteins would just start growing on the cells as if they are plants in there, do me a favor, look up MHC1, and 1 being an I here, MHC1 loading. Or look at, and you can look at the images to see the mechanisms. Here is a mechanism, for example. Or you could say MHC2 MSC2 loading, and 2 is being II. And once again, you can see the mechanism for loading. So what happens is that foreign antigen that enters our body is taken up by the cells, and then it is broken down. So here the messenger RNA is taken up, it is converted, it is used to make spike proteins. Spike proteins are then broken down into smaller pieces. Then they are loaded on MSC1 or MSC2. Then they are exhibited on the cell surface in a very controlled manner, either on MSC1, major histocompatibility complex 1. This is present in all nucleated cells, or MSC2, which is present also in the nucleated cells, but not all nucleated cell. It is present on specific cells, and these are called professional antigen presenting cells. These are B cells, dendritic cells, and macrophages, and that's it. So these cells will then present pieces of spike protein, broken pieces. This is like you take a glass, you throw it on the floor, you break it down into smaller pieces, and then you show one piece at a time to say, I have this piece here, and I think we should react against it. That is how the immune training would start. So if I go back to the question here, will the genetic material go to the brain, for example, or other places? If any lipid nanoparticle opens up out here, I do not know why it would open up, but let's say if it opens up and messenger RNA comes out here, then there are, in the tissue, there are things called RNases. Why are there RNases? RNases means that the enzyme that would break down an RNA. And once again, I'll continue to show you here just so you can do your own studies. RNases, ribonucleases, and you can go to Wikipedia or other places and you can see that they are present as well in the body. So what they do is they find any RNA, they're going to break it down. And why are they sitting out there? They thought there was going to be a vaccine there. No, they're sitting out there because our own cells continue to break down or release accidentally the RNAs outside, and that's fine. Those RNAs can come out and these will be digested right away. So then you can say, well, those digested pieces of RNA are sitting here. What would happen now? Macrophages are the big cleaners of the system. They would remove the trash. Macrophages' job is to pick up those debris, as we call it, and remove it. So the macrophages that are present in here, they're going to eat it up or phagocytose it or pinocytosis and further digest it to its smallest pieces and either use those or regurgitate those amino acids. And that's nothing. We eat food and that becomes amino acids. So there is no concept of somehow mRNA going out or the spike protein somehow. So there is one possibility of making spike protein come out of a cell. That possibility is, let's say this is a cell, and this cell was happy little cell, and it was got the vaccine, it was making spike proteins, and we were actually breaking down those spike proteins. So these are, let's say, spike proteins. We were breaking them down in endosome and presenting them, but in the meantime, when it was presenting the antigen, some other immune cell, for example, let's say cytotoxic T cell, or let's say a natural killer cell, some other cell came around and checked this cell out and said, well, it looks like you're infected, it looks like you're not doing well, and it kills it. When it kills it, or the local inflammatory reactions cause cells to come and kill the other cells over here, and now this cell opens up. When this cell opens up or breaks down, this is apoptosis occurs, these spike proteins come out. Now, there is a chance you can say in theory that these spike proteins should go to brain. Number one, they're coming out of one tiny little cell. Number two, immediately the same interstitial cells, macrophages, neutrophils, these are going to start eating these proteins up and breaking them down. This is actually a feast for them, and this actually would improve the immunity because they would eat a spike protein now, and they would break it down and present it, and then once again, immune system will be trained. So it is very difficult for a spike proteins to get to the brain, and there are not enough. Anyways, so hopefully, Vanilla Bean, that answers that question. How are things in Madagascar? I hope things are better there. Actually, let's see, how is Madagascar doing in honor of the Vanilla Bean. So let's see if I can now spell Madagascar. So there is a wave going on right now. Active cases, although less, but still 6,572 active cases, and deaths are following that as well. Anubhav says, in India, they found out that AstraZeneca is able to neutralize the Indian variant in vitro. 50% of the elderly also have been vaccinated, and they seem to be getting much lesser infections. Your thoughts? And I discussed that yesterday as well. Look, I have been talking about the vaccines and their effect on variant, and I've said that vaccines are going to be able to take care of the variant. And we see in Israel's case, so you don't have to take my word for it. Look at Israel's case. Now they have a variant. They have the B117, or the Kent variant, or the UK variant, as we call it. And then I think the South African variant is low there. And they were able to, their vaccine is able to handle it. So the point, once again, yes, there are in the Indian mutation, or 617, let's say this is the S1 portion, and this is the receptor binding domain. This is S2 portion, and this is the fusion protein. And there are some changes. And this, let's say this is S1, and this is S2. And this is our little spike protein. What we're talking about is that spike protein has, for example, in the double mutation, we actually have 13 mutations. 13 mutations are actually lesser than the UK mutation, which was 17, or South African, which were also similar in number. So smaller mutation, but two, we call it double mutation because there are two mutations that we are already afraid of. And these two mutations are on the receptor binding domain, which increase the contagiousness of the virus, or they make it fast to infect. But the remaining virus, or even just the spike protein, is still a large protein chunk against which a vaccine produces efficacy and produces antibodies. So what we are really saying when we say that, hey, vaccine would just not work, what we are saying is that all those extra and my apologies, since the morning my sound is this way, it's not warmed up yet, so apologies. So here we are saying that out of all the antibodies, every one of them is working, but maybe one is not working, and even that is a chance that it is not working. It is not necessary that the vaccine based antibodies that have been produced will not work. They might still continue to work, but even if one of them is not working, then what? There is a lot more of antibodies. So it is like this. I'll give you this example. If you look at my hand, let's say my hand is a spike protein, and we make an antibody against every finger. And you say, you know what? This lower part of the small finger, there is an antibody that would go here, and that antibody is not being produced anymore. But there are antibodies against every other part of this hand. And we say, well, I'm really concerned about this one piece that would be missing. No, you should not be, because the spike protein of the new variant is still being coated by the vaccines generated antibodies or previous infection generated antibodies, and will be fine. So from a mechanistic point of view, we'll be fine. Vanilla Bean says, Madagascar is doing bad, but no testing. Sorry to hear that. Hope that. So are the folks doing social distancing or masking? So Hemi, Colin Hamel, we talk over emails as well, so or Zoom too. So he has asked me to call him Hemi. So Hemi, I knew that Hemi, you were going to ask me this question next. Would it make sense to infect people with the rhinovirus when testing positive for COVID to see if they get immunity against COVID? Yes, in theory, but who would want to expose patient to another infection? I would never do it. So in theory, it is possible. The best way to do that is to actually test that in a petri dish, then test that maybe in a tissue, then see if humans who have been going through this, many humans during the winter time must have had SARS-CoV-2 or the common cold. They're not reporting a lot the common cold. They're staying at home, and they're getting very less of common cold as well because of all the hygiene related exercises. But if an observational study could be done where you see that what is the incidence of the SARS-CoV-2 infection in those who also had common cold, so that could be an observational study instead of a randomized controlled trial to say, let's infect people with rhinovirus. Don't know what would be the outcome. The study that I showed was in vitro. So please, this discussion should not mean, Hammy, I'm looking at you. It does not mean that you go and try to get common cold. Rahul says, vitamin supplements after the AZ vaccine. So standard vitamin supplements that we have talked about. Imagine this, that you take a multivitamin daily dose every day. So that should be done. On top of that, the vitamin D may be slightly more, and then vitamin C and melatonin and CoQ10, NAC. These are important and strong vitamins to continue to take. BIPUL says high vitamin D serum and budesonide will save life in COVID-19. So budesonide has been shown to be very, very protective. Can I say it would save lives? It depends. Some people would still end up in hospitals. Unfortunately, some would die. But budesonide is showing very good results. Now, vitamin D serum, I do not know. I have not heard of giving someone vitamin D serum. I think oral vitamin D should be sufficient. And I want to thank Nick. Just like Cool Bean support me a lot, and Margaret has been a tremendous supporter as well. Similarly, Nick has been a tremendous supporter in this way that not only Nick is a patron, but he continues to add. Nick is a physician. So Nick continues to add value by answering questions or putting comments. So Nick, really, really grateful for your help. Hugo Chousal says, I took my second dose of Moderna 3 weeks ago. I seem to no longer have an appetite. I'm 6 feet 1 inch, 170 pounds. Just wondering. Hugo, 3 weeks ago. So I think it's an important thing to figure out the history itself. When did it start, and does it change at all or not? The best is, I cannot give an opinion from here. I can explain loss of appetite, the reasons for that. So let me just quickly explain them. And please don't get worried with this. This is just how loss of appetite occurs. And you can talk with your doctor. So I'm going to keep it very simple. The simplest reason for the loss of appetite. So let's say this is a stomach, and then we have large intestine, not after the stomach, but in my drawing. Here we have jejunum. I'm sure that some medical students are going to say stomach and then large intestine. So jejunum, and then ileum, and then large intestine. The absorption occurs majority in the small intestine. And then all of this material continues to move through the small intestine, then the large intestine, and out. This is the pathway. The movement is done by something called peristalsis. Peristalsis is the movement. Imagine if you have a pipe and we kind of rub or squeeze that pipe in a wave fashion, so from one side towards the other side, and that would bring the material from one end towards the other end. That peristalsis sometimes slows down or stops. That can cause loss of appetite. Sometimes small inflammation in the GIT system would cause the GIT not to work very well, and may not even cause pain, but could cause loss of appetite. Then there can be neurological reasons as well, which I would not suspect. You wrote a question over here, so you seem to be fine. So this is more of a GIT, maybe mildly inflamed or have less peristalsis in it. And ideally it should go away, but please talk with your doctor as well. My son received Pfizer and he had GIT symptoms after that. And he said, I don't feel like eating anything. So he had loss of appetite, he had GIT symptoms, and now he's recovering. So, Arun, IVIG is at the end of the day immunoglobulin. Let me take this up. Arun always has some deep questions that need a larger set of concepts. So let me take it up that IVIG mechanism of action. I would do that in context of autoimmunity, in context of COVID. Rajesh is here. Rajesh said, is half-life of vitamin D 5 weeks? Vitamin D's usage, instead of half-life, usage depends upon our body's requirement. So if our body is going through actively an infection, then it is going to use the vitamin D more quickly. Or if we are exercising or working, our vitamin D is going to be used more quickly. So it is really usage based compared to the half-life as storage based. Peking says, is it just coincidence that the variants of concern are from the same places that the trials took place? I don't think that there is this is even attached. For example, the 117 variant or Kent variant started, let's say if you say the Kent was under trial, there was a lot of people in UK that were going through the trial, and now there are a lot of people who have been vaccinated. So if there was any such reason that the variants would occur because of the vaccination, then there are hundreds of millions of vaccinations now. There would be tons of variant, or if just trial 20,000 people getting vaccine. So in a trial of 40,000 people, 20,000 would get the vaccine, 20 would not. So in 20,000 people, let's say in the Kent area, out of 20,000, a smaller population is there. And if we're saying, well, 5,000 people got vaccine and we got a variant, then how about 30 million getting a vaccine? Or how about in Israel, let's say 6-7 million getting a vaccine? How about in the US, hundreds of millions getting the vaccine? Why are there no variants there? So this sort of is a rumor, if I would say it. Vanilla Bean says, mask is strictly compulsory in public. Here, all schools closed. What is the best way to get in touch with you if we would like to set up a meeting with you or our Ministry of Health? So the best is to send me an email or tweet at me, support@drbean.com, and just send a tweet. My team would see that email, just say that, hey, Mubin asked us to connect with you. And then they would connect with me. We'll exchange telephones and we can talk. Nowadays, it is becoming very, very common that people try to find my phone, and instead of mine, they just find my wife's phone and just reach out to her. So let's do another 2 or 3 questions and then we stop. Meanwhile, please like, subscribe, and share. The best you can do, if you can support the channel, awesome. If not, just hit like. That has a YouTube algo that, hey, this is something useful, and algo would then promote it to more people. So that is one way to supporting it. And if you wanted to support in general, then there are 3 links in the description. One is to buy me coffees, another one is to become a patron, and then another one is to support this channel in general. So with that information, please like, subscribe, and share. I'm going to see Eric Doc's question. What is maximum supplement of vitamin D, assuming no sunlight and not too much to produce kidney stones? So the standard RDA, I have discussed those studies, that there is a study that has said that there is a statistical error in analyzing the right dose. So instead of 1,000 IUs or 800 IUs or 400 IUs, the international unit should be somewhere about 8,000 per day. So my thinking is that it would really depend upon, as you said here very correctly, that it depends upon the exposure to sunlight and the chances to making for making vitamin D. So if somebody is not making vitamin D at all, or there is sunlight and that sun is not at a good angle, or there is sunlight and they are packed up in clothes, then they would need lots of vitamin D. And the need is, of course, if you go to government or these agencies, they would say 400 international unit per day, which is kind of a joke, but they say that. And then 800 for women, and then the study said 8,000. It also depends upon the person's activity, because at the end of the day, vitamin D is going to be used up in the cells as you are doing your activities or combating the viruses or having immune cell systems working. So all of that would actually pitch in. So the best is to, I think, if not, so for example, in case of William, he kept taking 10,000 per day to tip it over 100 nanogram per milliliter. So keep it near 50 or 60, and I think that is good enough. And so 5,000 to 8,000 international units. I always give a break for a couple of days as well when I'm taking it. I had been taking 20,000 units at one time. So one last question, Jessica Milton. My mom has short-term memory problems, not dementia. They want to give her antidepressants in theory, and as it treats the brain, could that improve or make memory worse? The memory are of many types, right? So there is a retrograde memory, that means recalling past events, and then there is antigrade memory, and that is making new events. For example, right now when we are talking, we are making antigrade memory. You're listening to something, and then hippocampus is kind of processing that, and then it is creating hooks in the brain with this chain of thought which is occurring in your brain right now. So depends what is the area. Is it the antigrade memory issue, or is it the retrograde memory issue? Most commonly it is an antigrade memory issue. So now going back to the question that they want to give her antidepressants. Antidepressants actually do not cause, they can improve memory. And here is why. If I just very quickly provide a conjecture here. So some of the memory issues occur because in the brain stem, we have reticular activating system, which, to my amazement, the folks who do this inspirational talks, motivational talks, and I listen to them as well, they talk a lot about ascending reticular activating system and doing everything, and they just keep connecting weird brain structures into that, and they know nobody knows it, so they just say it. So ascending reticular activating system is a system that would help keep brain in a wakeful state and alert state. So many antidepressant would help produce those neurotransmitters that allow the brain to stay in a more alert and balanced state. So that should actually ideally improve memory. In depression, memory becomes patchy as well. That is not a problem with the retrograde memory or antigrade memory. Most of the time that is just the inability of the person to pull on the memory threads to be able to recall them because of the depression and the state of mind. So let's stop here. Once again, thank you very much for your questions, for being here. If you would like to join us, so Dr. Bream, B-R-E-A-M, B-R-E-A-M. So it is funny, I'm Dr. Bean and he's Dr. Bream. 2 o'clock Pacific Standard Time on YouTube. You can just search for Dr. Bream and his channel would come up. We'll be live, and he wants to talk about leronlimab, he wants to talk about tocilizumab, he wants to talk about ivermectin, he wants to talk about the remdesivir and why it is useful or not, and so on. So he wants to talk more about therapeutics and where do they stand and why they are good or not good. So we'll go from there. Maybe you can come join us as well. Thank you very much once again. Please like, subscribe, and share. And if you would like to support this work, there are 3 links in there. And if Roman is listening, I am gonna, so last week became very busy with the conference preparation. So I'm gonna continue my discussion with my team for 501. So thank you very much.